We will be today doing just a presentation on ultrasonography of gallbladder, as it is a vital organ, and imaging is very vital to know about the pathologies of gallbladder. So this is a famous quote by Winston Churchill that success is not final, failure is not fatal. It is the courage to continue that counts. Starting with this. So what is the basic sonographic technique that we use for evaluation of gallbladder? You can see this is the GB fossa region, and you can very well see that this is the gallbladder within the GB fossa. This is the liver, which is anterior to the gallbladder, common bile duct, hepatic artery, IVC, portal vein. These are all the vascular structures which are adjacent to it. So whenever we perform a sonography for gallbladder, we should include both the transverse and the sagittal planes. In addition, we should perform a focus scan to assess the porta hepatis, length of these hepatic arteries, and the face of the transducer should be directed towards the right shoulder. So once we have the orientation to look where to look for gallbladder, then we can sweep the transducer from shoulder to the umbilical region, and we can see various vascular structures like the right and left hepatic ducts at the porta hepatis. Then we can see that followed by common bile duct, and then IVC and aorta. So while sweeping, we will see all these structures. You can see the CBD here, followed by portal vein. You can see hepatic artery, IVC, and aorta, and there is a gallbladder. So again, when we are not sure about what we are seeing, like is it a vascular structure or is it a duct, then we should use Doppler. So once we put the Doppler on, we can very well see color vascularity within the vascular structures, whereas the cystic structure or duct won't show any vascularity. So these are the images of gallbladder with the ducts. So this is the technique. We should see in left lateral decubitus position or left posterior oblique position. In right subcostal approach, you can see that the transducer is facing towards the right shoulder. So then we can very well see the landmarks. The portal vein is a valuable landmark, and also the common duct. So once we have localized the gallbladder, we can see the most common pathology that one should be aware of is gallstone disease. So ultrasound is highly sensitive for detection of stones within the gallbladder. A large difference is in the acoustic impedance of stones and adjacent bile that makes them highly reflective, which results in echogenic appearance with strong posterior acoustic shadowing. You can see this is the gallbladder in these hyperechoic structures within the lumen, and they are giving shadowing. So we can't very well identify the posterior wall even. So these are all gallstones which are within the gallbladder lumen, and these are mobile stones. So once you change the position of the patient, these stones also change their position. So again, a diagnostic point. Sometimes you see level within the gallbladder lumen. That is when we suspect sludge. So this is a case of biliary sludge. Stones which are within, they are like drowned within the sludge. And the sonographic appearance of sludge is that of amorphous low-level echos within the gallbladder, and it's always in a dependent position with no acoustic shadowing. Once the gallbladder wall becomes inflamed, then the condition is called acute cholecystitis, and patients usually present with constant pain in the right upper quadrant, and clinically there can be fever, leukocytosis, and increased serum ELP and bilirubin levels. This is the table which is demonstrating acute calculus cholecystitis, pathological and pathophysiology and sonographic appearance. So whenever there is an obstruction in the cystic duct or the neck of gallbladder, you should suspect stones, and sonographically you can see the stones in the gallbladder or in the neck region. Then there can be inflammatory changes, there can be GV wall edema, there can be hypervascularity, Then there can be bacterial overgrowth within the gallbladder, empyema, increased pressure in the GB lumen, gangrene, perforation. So whenever there is such clinical presentation, then we should see like thickening of gallbladder can be well appreciated. Murphy's sign is more than diagnostic for cholecystitis in more than 90%. Hyperemia, biliary sludge. Then you can see echogenic layering within the lumen of GB. And sometimes you can see clogged membranes, hypovascularity. In case there is loss of Murphy sign, then you should suspect gangrene. And in case of perforation, you can always see collection which is adjacent to the GB fossa region. So you can see this is a case of acute cholecystitis. There is a stone which is giving shadowing, acoustic shadowing in the posterior aspect. This is a big stone which is embedded in the GB neck and causing layering sludge within the GB lumen. Walls are thickened. Circumferentially also you can see, while you put the Doppler, you can see the vascularity. And the cystic artery here, color Doppler can again help you to identify these vascular structures. Same spectrum of appearances you can see within the GB lumen, multiple sludge, CT just to confirm our diagnosis. But ultrasound is highly diagnostic, and USG is very informative for such patients. Okay, next, what are the causes of gallbladder wall thickening? It can be because of congestive heart failure, renal failure, cirrhosis, hyperalbuminuria, various inflammatory conditions like acute cholecystitis, cholangitis, chronic cholecystitis are the primary causes. Secondary causes are acute hepatitis, perforated duodenal ulcer, pancreatitis, diverticulitis, neoplastic conditions, gallbladder adenocarcinoma or metastasis can cause GB wall thickening, and in miscellaneous conditions like varicosities and adenomyomatosis. So this is systematic GB wall edema. You can see thick GB walls here, and then there is sludge, calculus within the GB lumen. Again, this is wall edema, diffuse wall edema in the GB. Sometimes there are calcifications within the GB wall. So this kind of appearance is called porcelain gallbladder. Because of the appearance, the name porcelain came. The degree and the pattern of calcification determines the sonographic appearance. When the entire GB is thickly calcified, you can see a hyperechoic semilunar line, which is dense posterior acoustic shadowing. You can see the calcification along the wall. So that's when you get the shadowing behind the walls. And mild calcification can appear as echogenic line of variable degrees, because the calcification can be new or it can be old, so you can see variable degree of shadowing. Like here, just CT is showing you the calcification along the wall and in the... So this is a dense calcification at the fundal region, which is appearing like a stone. But this is a porcelain gallbladder, which was... CT was more conclusive in this. So repeatedly, if there is inflammatory changes within the GB, then it is called chronic cholecystitis. And so patients can be asymptomatic or they can have mild disease. More advanced cases which will involve thickening and fibrosis. They can have thick gallbladder, and sometimes they may have gallstones also. So how to differentiate with the acute cholecystitis made by absence of other signs like GB distension, Murphy sign, and hyperemia. If they are not present, still you see thickening in the GB wall, then you call it as chronic cholecystitis. And always before chronic cholecystitis, the patient will have a history of acute cholecystitis, adenomyomatosis or adenomatous hyperplasia. So GB adenomyomatosis is a benign condition caused by exaggeration of normal invagination of luminal epithelium or the Rokitansky-Aschoff sinuses with associated smooth muscle proliferation. The great majority of adenomyomatosis are asymptomatic. So adenomyomatosis is diagnosed basically on ultrasonography. So what do we see? We see tiny echogenic foci in GB wall which create cometal artifacts, and prominent mass-like focal area of adenomyomatosis are called adenomyomas, and echogenic foci with ring down or twinkling artifact on Doppler examination are typical. So you can see this is an example. You can see comet-tail artifacts behind these echogenic foci. These are cholesterol granules, which are pre-indicators for adenomyomatosis. And then approximately half of all the polypoidal gallbladder lesions, these are the polypoidal masses. Sometimes there are masses in the GB lumen. They are basically cholesterol polyps, inflammatory polyps. They can be adenoma. There can be focal adenomyomatosis or GB adenocarcinoma and metastasis. So approximately one of all the lesions are cholesterol polyps, and they represent the focal form of gallbladder cholesterosis, a common non-neoplastic condition. So polyps are predisposing factors for GBB carcinomas. So wherever you see such polypoidal lesions, their number, they can be multiple, they are ovoid, and you should always concentrate about the size of these lesions and follow them up. So once patients, they can have a mass arising from the GB fossa, which can obliterate gallbladder and invade digestion liver. There can be focal or diffuse irregular wall thickening in the GB and interluminal thick polypoidal mass. Then you think about GB carcinoma. So you should go for Doppler. You should see how vascular the lesion is, and if there is malignant thickening of the walls, is the wall irregular, or there is loss of normal mural layers. Then polypoidal interluminal masses can be differentiated from non-neoplastic by immobility, and if they are more than 1 centimeter with vascularity, they are more likely to completely GB carcinomas. The gallbladder is abnormally distended. Again, you should suspect GB carcinoma. This is the case. You can see a big lesion within the GB wall. Here again, polypoidal lesion, and you can see malignant thickening of the wall. So, case of malignant GB carcinoma. Again, you can see that this has spread now. There is infiltration associated with the thickening. So this, you can't see the margins of liver and GB separately. So this is a case of GB carcinoma. And some facts about biliary tree, because GB, when you see, you should know that what is the normal dimension for CBD and CHD. It is up to 6 mm, and up to 10 mm they have been in some places where it has gone up to 10 mm, but majority of the diameters are under 7 mm. So that's why, according to the new guidelines, the 7 mm is the criteria for the CBD and CHD. So less than that is considered normal. Thank you. That is all about gallbladder imaging. See you in the next one. Thank you.